Welcome to Eurofins Viracor Clinical Diagnostics Podcast, where I'll be sharing up-to-date scientific advances, key diagnostic testing, and our most recent innovations. Enjoy Part 5 of our 10-part series, originally broadcast live from ATC24 in Philadelphia.
Welcome to Eurofins Transplant Radio Viracor Views. We're live at ATC24. Have the pleasure of sitting down with two of the most stellar PharmDs in the industry, and we're really glad to have you present with us today. Joining us, we have Mary Chandran and Christina or Chrissy Dolangowski, going to talk to us a little bit about transplantation, the roles of the PharmD in transplantation, how you got into this particular aspect of your clinical career, and the good, maybe a little bit of the interesting. We're not going to talk about anything bad here as we go, so I'll let you two introduce yourselves, and if you've got questions you want to talk to each other about or like that, that's great. I've got a couple I may chime in to see if we can stump you.
Perfect. All right, perfect. Hey everyone, I am Chrissy Dolangowski. I've been a transplant pharmacist for almost 15 years, going on 15 years now. Love it. Have been both in North Carolina as well as down in Florida. Currently work for the University of North Carolina Health and primarily practice with our outpatient heart transplant and lung transplant teams. And really love the opportunity that I have to have a more longitudinal role, get to know patients, what their situations are, really kind of craft a bespoke plan for their medications and for what their goals are and what's going on, both from their health perspective as well as kind of a personal perspective, which is really wonderful, and really excited to sit down with Mary today and talk about all the wonderful things of transplant.
Absolutely. Thank you, Chrissy. So yes, my name is Mary Chandran. I am also with Chrissy at the University of North Carolina Health, but my particular focus is below the diaphragm, so working with our kidney, liver, and pancreas transplant recipients. I'm not necessarily a Tar Heel from birth, but I've been there a good long while. I trained at UNC for residency training, and then worked at University of Maryland, and then did some pediatric transplant for a few years in Colorado before coming back to be in Chapel Hill. And to your question about what got us into transplant or what our journey, personally, I fell in love with transplant in pharmacy school, from the complexities of the pharmacotherapy and all that goes into managing these patients, all of the therapeutics that it requires, the testing that we have to do, and then you add in the additional complexities of infectious disease, developing malignancies. And so as a pharmacy student that didn't quite know what I wanted to do, this sort of encompassed everything. You get the critical care, the follow-up, and so I really piqued my interest and then was able to do more and more of it in my training, and really just was sold. This is a great population to work with, but also you get to use all those muscles, I feel like, as our pharmacy skill set allows us to do so.
That's really good information. So, and you both work, pediatrics through geriatrics in the way of transplantation, therapies, follow-up, and et cetera. Gonna throw this out there, just something I've pulled off, I forget which one of your social media feeds, so yes, I've been stalking you. We'll learn a bit more about you, but you talk about how PharmDs are an essential part of the transplant team, and transplantation, it's not just the surgeon, it's not just the surgical folks in the OR and like that. It's from diagnosis through transplantation and then through recovery and getting on. Could you expand a little bit on that aspect of it?
Yeah, absolutely. One of probably my favorite things about transplant is how multidisciplinary and how team-based the approach is. Some of the most important team members that I work with are nurses or nurse coordinators, but I do think that pharmacists have a very unique and special role within solid organ transplantation, at least in our current era of what immunosuppression and transplant looks like until we have really robust xenotransplant, we're all going to need medications to have successful transplant. And as I like to say to my patients, these medicines don't play well in the sandbox with a lot of other things. And so they require intensive monitoring, adjustment. And I think that the most well-positioned folks to do that work are pharmacists. To bring that level of pharmacotherapy expertise to the patient population, whether it be their immunosuppression management, whether it be their diabetes management, whether it be their bone health management. Pharmacists are really well positioned to manage and think about every aspect of that.
And we're trained and well equipped to be able to do that spectrum of disease states. So, you mentioned that from the diagnosis, and I would say even before that, when we have patients developing end-stage disease, and not necessarily even just transplant pharmacists, we have pharmacists that are specialized in hepatology and nephrology that really understand those disease states, and then we sort of transition as they cross over into our realm. And I think something Chrissy and I get to do a lot in our clinical practice in the ambulatory care setting is, of course, we're taking care of that transplant recipient's allograft and managing their immunosuppression, but we take care of this patient as a whole. And so appreciating that they have several comorbidities, they need to be managed by multiple disciplines, medical and beyond. And really, in a lot of ways, I think we can bridge that gap. We work really closely with other pharmacy disciplines and medical disciplines and can help with a lot of those transitions of care and sort of filling in to make sure that we're kind of catching everything and not just looking at the patient from that one sort of niche perspective.
Very good. And you kind of answered this question, but I'll throw it back out there. Maybe there's some additional points you want to talk about. So what do you find to be the most valuable aspect of your work?
There's a lot of things. I think the biggest thing I enjoy the most, and I hope is a lot of my value add, is just seeing that long-term improvement on patient health. We know these patients from transplant and beyond. We take care of them very, very continually and comprehensively, and really seeing someone go from being incredibly ill to being fully functional, back into the workforce, active with their family, really living life the way they want to live, and that transplant giving them that opportunity, but knowing that we're helping bring them to that, and meeting them in all their needs so that they are healthy enough to live a long, fulfilling lifestyle. And I think it's nice to be able to be part of that. You get to know these patients personally. We hear about their families, we catch up with them at their visits, and I just think that's something that's so unique with transplant, is that we get to see them from that spectrum of the very bad and the very scary to being, much more well, and being an integral part of that puzzle and that process is something I take a lot of value in personally and pleasure in being a part of.
And I would echo that. I feel that same way. Another aspect that I find particularly rewarding is to get to serve as the translator for many of the situations for patients and the other healthcare professionals. I think as a pharmacist, we often have the ability to, or we're in the role to explain, really complex either immunologic or infectious issues in a way that our nurse coordinators understand it and can really help facilitate good patient outcomes. We can teach that to the patients and why it's important that they come back for lab monitoring, what CMV is, but then we can immediately jump into a physician workroom and have a really in-depth discussion about the merits of one therapy versus another, what the data says, we should be doing. And so getting to have that spectrum of conversation and talking even about something like, a CMV T-cell assay, explaining it to a patient, explaining it to a nurse, talking to the physicians about the data behind it is incredibly valuable.
Yeah, very good.
Absolutely.
And it leads me, I guess, into my next question. I mean, you've been in the business for a couple of years, and so you've seen changes in therapeutics and diagnostics. How has that helped you, hindered you, or confused the heck out of you, and how to proceed forward in this?
I mean, to me, I I was last in Philadelphia when I was a pharmacy resident in 2009, 10, for ATC. Was the lowly resident who didn't have a job yet, was trying to figure out what life would look like, and now coming back, I think what I'm most struck by is the diversity and depth of non-invasive testing and diagnostics that we now have in our toolkit. Whether it be rejection surveillance, infection surveillance, it is impressive that if you can put several pieces together, you can really have a good sense of what's going on with a patient, all from just blood work, without ever having to biopsy that organ.
You know, we've been talking about precision medicine, individualized therapies for years, right? That's the ultimate goal. But when I was in training as well, it was very much, even though we knew it wasn't the reality, it was a one-size-fits-all approach to most transplant recipients. The protocol suggests this is the pathway you stay on unless we need to veer off, usually for reasons that are not desirable, you know, that there's complications. And now we have so much more information. And to your point, sometimes we don't know what to make sense of it all. We're still trying to figure it out. But when you're looking at this patient and you have all of that information in front of you now with much more diagnostics, you feel as though you're making a much more educated decision about the right, you know, course of action for that patient, you know, and making, you know, it helps to solidify where you're at, but also it teaches us things. You know, we as to your point, when we don't know what we're doing, well, we have to make a decision and then we follow that. And then we steer our course in a different direction. It's like, okay, well, that didn't work last time, but now I feel like I understand this a bit more, or I should check something in addition to help guide me. But we're much more looking at patients in the individual and where are they at on the spectrum of their immune, you know, status and their infection risk, as opposed to, well, this is the protocol and we really want your goal to be this because, and then sort of being a bit hand-tied because we don't have anything else to tell us otherwise.
It's more of a proactive approach rather than a reactive. I feel like we very much were in a space 10 years, 15 years ago of, oh, they got this complication, let's react to that. And now I feel like we're in a space where our non-invasive testing and the tools and the precision medicine that we have allow us to proactively anticipate those issues and prevent them from occurring.
Very good.
And I would say what I'm most excited about, I don't think I'm not fully there yet, we're getting there, right, is that Chrissy and I are constantly adjusting immunosuppression. And we often wonder, what are we doing by doing such things? And I think a lot of these diagnostics, as we learn to use them and apply them more, is can we actually identify the changes that we're making? Can we measure that impact with these testing? I think we can, as we continue to get more familiar. But that also gives us more comfort when we make these changes and we're not sort of just crossing our fingers and toes that it works. We have a little more data to let us know, did we make the right choice or do we need to do something different, something else?
Right. So, I mean, quick, accurate, effective diagnostic tests for, so you can make those changes, you can monitor those changes, and then you can make the determination, did this work, did it not work, okay, what's my plan B, plan C, where we need to go with this. Now, Chrissy, you had talked earlier a little bit about xenotransplantation. We know that that's on the forefront. We've had 2 heart transplants with xenotransplants, a couple of kidney transplant patients. They've learned a lot from that. We're all learning a lot from that. What do you think the challenges are going to be going forward to you and to the transplantation team?
Gosh, I think it heralds back to that initial era of, human solid organ transplantation, where from, at least my mentors and folks who have been in transplant for a while say, guys, it was just the Wild West. We just did kind of whatever we thought was best. I think it will allow us to integrate and use that basic and translational science a whole lot more than what we maybe are doing right now, because to be honest, we have a really reasonable set of immunosuppressive therapies and approaches and protocols. Like, we can do regular transplant. I think going into Xeno will be be just a really exciting time for the field, and that opportunity, as to steal Mary's term, to really flex all the muscles of our brains to think about what it is that we need to do and what does the basic science tell us about how we need to treat a patient in the real world clinical space.
What are your thoughts, Mary?
I very much agree with Chrissy, and I think it's so early. It's so hard to know where we're going and what that's going to entail from a therapeutics perspective. And I think we've barely even scratched the surface on what that will look like and where we'll come into that picture. But I certainly think, human solid organs will remain. I think that there will be now more of a mix of what type of options patients have available to them, and really getting how do we apply these agents, especially in when there's probably, I imagine there'll be some genetic modifications and things that will lower rejection risk, and how does that translate into the therapies that we give them, and what unforeseen complications will we be helping with down the road as well. So I think it's very exciting, but I'm not even going to try to guess what it looks like. I'm sure because I don't want this to be replayed in a few years and then I'm told how wrong I was.
Or you're speaking, this is the here and now, and we really don't know what tomorrow is going to bring. But I think with the way that medicine is evolving and adapting and understanding, transplantation is a significant need out there in the population. They've made great inroads lately, and determinations of before a CMV positive person could not be a donor. Now they can be a donor. Some of the other viral diseases and maladies and like this, the studies have been made that this can be a viable organ to transplant, and then that has just significantly increased the availability of organs because they're very, very short, and there's much more of a need for those that need a transplantation than people that are willing to donate the organs to it. So what are your thoughts on living donors? Giving up a kidney, a piece of a liver, maybe a lobe of a lung.
Yeah.
I mean, it's an amazing gift for someone to give. I think it's amazing in terms of outcomes for the recipient, and the more living donation I think that can occur, the better in terms of patient outcomes. I think there's a lot of education that goes into it, but there's so much more for the general public. But I think it's a tall order. I don't know. You're not going to necessarily have a line around the block, but I think if you have a family member, a community member that is in need, and it's a safe procedure. There are sort of catch-alls for these individuals down the road. Should they ever need a transplant, there's opportunity. They would have sort of priority in the setting of getting a transplant for themselves. And so I think there's a lot around it where it is safe. It's obviously very effective, and I think the education though and the community at large is still something we can continue to improve upon for just the general understanding of what donation is, deceased and living, to be honest.
Right.
Yeah, absolutely. I mean, I was just going to add in that deceased donation and myths and misnomers about what that entails, what that means for a loved one, how much care is provided. That is something that, as a transplant profession and community, we can really get out there and do some more work to make sure that folks know that this is a viable option and that your loved one will be taken care of to the fullest extent. I'm really excited to see, in addition to all of the diagnostic testing, all of the organ perfusion work that's happening to really expand the ability to take organs, recover them, especially when it comes to heart and lung transplant. Oftentimes, lungs get bogged down in a lot of fluid to keep kidneys going great. And so the ability to be able to take those organs, make them, kind of optimize them before transplant, and then transplant them successfully is really exciting.
And there's been a lot of discussion at this conference about living donation in terms of increasing the donor pool by making donors, candidates, and that they would be approved for donation, and a lot of emphasis going into that, because there's often people who want to donate but maybe cannot for one reason or another, and some of those reasons are modifiable. And so there's a lot of discussion around how can we improve that living donor pool and people who are willing and ready, and that we may need to fine tune, and then discussions about what do we owe that donor with regards to follow-up care, and making sure they're receiving all of what they need in terms of follow-up and management after they've gone through with that surgery themselves. So it's very much, I think, a growing conversation within the community.
Very good. Very, very, very in-depth and illustrative points that you two have made on that. Thank you for sharing that. We're getting back to the end of our time here, but one last question for each of you. Since you're across from me, Christy, I'm going to ask you first, and this kind of gives Mary a chance to think about her answer. But so any fun facts about yourself that you'd like to share to our listeners?
Yes.
Or any fun facts about Mary that you'd like to share to the listeners?
No, friends never tell. Right? I think probably my favorite fun fact is that I do the New York Times crossword every day. I started doing that when I was home on maternity leave with my first son 8 years ago, to kind of keep my mind active, and I've been doing it every day since then, and I absolutely love it. It's kind of turned into a bit of an obsession.
So do you do it in pencil or in pen?
I do it on the app. So they have an app. Yeah. But I do it, I do not check my work. So I try and finish it as best I can.
That's good.
I'll say, I guess my fun fact, it'll be my New Year's resolution, is to make sure, we're having work-life balance, as I am making sure I read a book every single day for 2024.
So what book are you reading now?
It's not appropriate for air.
Okay.
No, just kidding. I would say there's a genre out these days called romantasy.
Okay.
So there's a little of a, love story mixed in with some dragons or fairies, if you will. So not for the faint of heart, but a good read.
It's good escapism.
Yes, exactly.
When you spend all day talking about life and death things, sometimes it's just really nice to get into a book or do something that takes your mind somewhere else.
Yes. And that's the beauty of books. We'll all sit in front of the electronic babysitter, the 65-inch electronic babysitter we have in our living rooms or whatever, and crimes get solved, medical miracles are made in 30 minutes or less, and like that. But literature, it really engages the mind and allows you to think and expand upon things. So,
and we both have young children, and I think personally I want to, of course, we use our screens, don't get me wrong, but to limit some of that too. And I feel like we have to show them we do things that are off the grid too. And so we'll have quiet time, and I'm like, everyone read your book. I don't care if it's a picture book or word book, but doing some of that quality time without always being tapped in, because I know I personally need to get offline for my own mental health.
My 8-year-old fights me to do the Wordle. I'm like, no, this is my time to do Wordle, and he's like, no, Mom, I want to do it. So I love it. Teaching him how to spell.
Yes.
5-letter words.
5-letter words.
Yes, hey.
Better than 4-letter words.
Yeah, I was going to say, there's worse options.
Well, thank you both very much for your time. Pleasure sitting down with you.
Thank you.
And I hope you have had a good couple of days here at ATC 2024 in sunny Philadelphia. And we've got about another day and a half left. So appreciate your time. And thank you very much.
Thank you.
Thank you.
Make sure to subscribe to this podcast and follow us on social media to stay up to date on all the latest information. If you want to help spread the word, please give us a 5-star review and tell your friends and colleagues to subscribe too. With over 40 years of diagnostic innovation and specialized expertise in infectious disease, pre- and post-transplant, allergy and immunology testing for immunocompromised and critical patients, Eurofins ViraCore is committed to helping medical professionals, transplant teams, and reference labs get results faster when it matters most. ViraCore is passionate about delivering value to our clients by providing timely, actionable information, never losing sight of the connection between the testing we perform and the patients you serve.